radiological assessment of upper airways. I will not be going into the diseases which affect the airway, but what are the ways by which we can visualize the airway by using the radiological modalities. So I will be talking more on the technique part, not on the disease part. Before going to the techniques, a brief anatomy, just a review of brief anatomy. So in CT scan, and this is the X-ray, this is the illustration. So in CT scan, we acquire the data in form of various axial slices in the area of interest. Like if we are interested in evaluating the airway, then we include the neck and thorax. And from skull base to diaphragm, we take the CT data, and various windows are available for visualization. Like this is the lung window, which clearly visualizes the airway, and this is the soft tissue window, which visualizes the soft tissue structures like muscle, vessel, any mass. So this is the level of pyriform fossa. This is the supraglottic part of the larynx. These are the aryepiglottic folds. So this corresponds to this level, just below the level of this vallicula and epiglottis. These are the level of pyriform fossa. So I have shown sections at the level of pyriform fossa. This is the section at the level of vocal cord. This is the base of arytenoid. These are two vocal cords. And on the X-ray, this is the cricoid cartilage. Just above the level of cricoid cartilage is the level of glottis. This is the lung window showing glottis. And laterally we have framework of the thyroid cartilage. And these are the sternocleidomastoid muscles, and these are the carotid vessels. And this is the thyroid which has just appeared. And posteriorly we have vertebra and parovertebral muscles. So this is the brief anatomy. Further lower down at the level of cricoid cartilage. So this is the level of cricoid cartilage. This is the cricoid cartilage. So it becomes a somewhat oval. And this is the level of cricoid cartilage on the lateral radiograph. And we have this thyroid gland on both sides, carotid vessels, sternocleidomastoid muscles. Then this is the vertebra and the parovertebral muscles. Further lower, this is the trachea in the neck region, surrounded by thyroid gland, anteriorly by isthmus. Again laterally carotid vessels. Posteriorly we have esophagus here, and then the vertebra and the parovertebral muscles. So this is the level of this section. So this is the trachea in the neck. This image showing trachea in the inside the thorax or intrathoracic trachea. Posteriorly this is the esophagus, anteriorly this is the trachea. Then we have these great vessels arising from the aortic arch, left subclavian, left carotid and right brachiocephalic. This is superior vena cava, this is left innominate vein, merovingium sterni. On both sides we have lung. So this is the brief anatomy of the intrathoracic trachea. And as we move down, the trachea will divide into right and left bronchus, and this point is called the carina. So this is the carina. Anteriorly we have the pulmonary main pulmonary artery, right pulmonary artery, left pulmonary artery. This is the ascending aorta. This is the descending thoracic aorta. This small structure is the esophagus, and on both sides we have lung. Posteriorly we have vertebra and paravertebral muscles, and this is the lung on lung window. So this is the brief anatomy. Now in radiology we have 3-4 important modalities like X-ray, which is the oldest and conventional modality. Then we have ultrasound, CT and MRI. But ultrasound and MRI are not very useful for the assessment of airways, as these air containing structures are better depicted on X-ray and CT scan. In X-ray, the problem is that there is always superimposition of structures. Sometimes the images are not very clear. So of course CT is better, and many a time these patients have a preoperative CT. the patients who undergo difficult thyroid surgery or with large masses, usually CT is done to see the vessels, to see the extent of the mass. So from the same CT data, we can evaluate the airways. We don't need to perform another CT to see the airways. From the same CT data, we can nicely evaluate the effect of mass on the trachea, bronchi, everything we can see, and I'll be showing you what are the techniques which are available with us. So these are useful not only for airway assessment, we also do CT in cases where some bronchoscopic intervention is contemplated, or there is a stenting which is planned for some trachea or bronchial lesion. So in these cases we are doing it regularly. So these are radiographs. This is the lateral, this is the AP radiograph. So we can see the airway, but in all patients, especially in obese patients, sometimes it's very difficult to see, but in some cases we can have a nice view of the airway, like this is the level of epiglottis, vallicula, piriform fossa, this is the level of glottis, this is the cricoid cartilage, then we have the trachea, this is oropharynx, and this is the nasopharynx. So all these things can be seen in thin patients. On AP view, we can see the trachea here. For intrathoracic trachea, the visualization is not that good because there is a lot of superimposing structures, but still we can see the trachea, carina, right bronchus, left bronchus, and on the lateral view also we can see the trachea. So in X-ray also we can evaluate, we can see the amount of deviation and the amount of compression. But in CT there are many post-processing techniques which can really show us it in a 3D way. We can rotate it, we can see in many ways. So what I am showing on this slide is that these are the kind of images we get from the raw data of the CT. We get the images in axial form, like slices of the neck or thorax. We have multiple slices, 1 millimeter or 2 millimeter slices. And we can change windows to see bones or to see lungs. So we have different windows available from the same image. We can highlight, like if you want to see the bone, we use different settings. If you want to see lung structures, we use different settings from the same data. Then we have lot of computerized things which really manipulate this data to show us the anatomy in like coronal plane. If we want to see the anatomy in coronal plane, we can see it like that. If we want to just see the airway structures, and removing all other structures, that is also possible. If you want to see the vascular structure, so there are different kind of processing techniques which will highlight different structure what you are interested in looking at. So these are the techniques. I am just mentioning the name. So we have MPR, MIP, MINIP, VR, external bronchoscopy and internal bronchoscopy. These are post-processing techniques that are available with us. I'll be showing you examples. So this is a case which I think it will be shown later on also. So we have a large mass lesion in the right, arising from the right lobe of the thyroid. Here you can see, and it's compressing on, here you can see it's compressing on the at the level of glottis, and this mass is having intrathoracic extension, and you can see how much compression it is causing on the trachea, and then this mass is going into the mediastinum and it is displacing the great vessels and it is reaching up till the carina. So, and this mass is abutting the aorta as well. So on the axial we can see the mass, but from the surgeon's perspective or from the anesthesiologist's perspective, if we can generate this type of images, like this is a multiplanar reconstruction. From the same axial slices we have generated a coronal image. So in one image we can see the entire mass, the extent of the mass from where to where it is going and how it is deviating the trachea. So for better orientation, this type of images are very useful. So this is called multiplanar reconstruction. We can, like from the axial data set, we can create images in any plane we are interested, like if we want a sagittal anatomy or we want in a coronal plane. So all those planes are possible. We just have to load the data and manipulate the data. So this is called multiplanar reconstruction. Another technique is called maximum intensity projection. In this, what we highlight the high density structures only. Like in this case, we have highlighted the vascular structures, bones and vessels. They are seen nicely. So the maximum intensity projection images from the same data, we highlight the high density structures and we suppress the low density structures. So we see by this technique we see the vessels and bony structures better. So in this case we can see the effect, how the vessels are deviated on each side and the relationship with the mass. So this technique is useful for seeing the vessels. But now as far as airway is concerned, because airways are air-filled structures and airs are very low attenuating structures on CT. So we have another technique that is called minimum intensity projection, where we highlight the structures having very low density. So in this projection you can see all other structures are blurred. We can only see the trachea and the lungs. So this type of projections are useful for seeing the airways and bronchi. So you can nicely see how the trachea is deviated, but lower down the trachea is having a reasonably good lumen and the carina is free. So all this kind can be seen on coronal as well as sagittal images. And you can also see the level. This is the level of epiglottis. This is the level of glottis. So distances can also be measured, like from how much distance we have narrowing, how much is the narrowing. So all these things can be done on these images. Now coming to the volume rendering technique. So the images so far I have shown, they are 2D images, but not only 2D, we can see the data in a 3D orientation. Like this is in volume rendering we like assign densities, and again we highlight the structures which are of our interest. Like in this case we have highlighted the air containing structures, and you can see the lung and the airways. This is the level of vallicula, and then this is the level of glottis, and this was the level of the narrowing which I have shown, and this is the level of carina. So this is a sort of external bronchoscopic images which we can generate from the same CT data, and we can also rotate these images in any plane, whatever plane and whatever degree of rotation. We can interactively rotate it and see it in relation to the mass lesions. So these are called external bronchoscopic images. Again, these are again the external bronchoscopic images. So we can see how much narrowed. Sometime in AP view the trachea looks not that much compressed. So that there may be compression more on the lateral view or the AP view. So you need to see the data in different rotations. Now coming to the internal bronchoscopy. So in addition to the external bronchoscopy, we can also generate images somewhat like bronchoscopy. Of course, fiber optic bronchoscopy is much superior, but still we have this technique. And the patient already has a CT scan, so we can use these techniques. Like in this case, again, I have moved from above to below. We can see this is the level of epiglottis. We have seen epiglottis. Then this is the level of vocal cord, and further down we can see there is a tight narrowing here. And then again distally we can see there is somewhat reduction in narrowing, and the caliber of the trachea has come back, and now we have reached till the level of carina. So again, of course, this is not the replacement of the conventional bronchoscopy, but we can do this in cases if you are planning putting some stent or to see the internal anatomy. This processing technique is also available. And here one advantage what we have is that we know that from where we are looking. Like when we do endoscopy, we are not that well oriented that from where we are looking, but when we do this kind of bronchoscopy, we actually know that at what level we are focusing. We have like our axial, coronal and sagittal images in addition to these internal bronchoscopic type of images. So so far I have shown you airways. So VR images are not only limited to the airways, they can show you the bony anatomy, the vascular anatomy, the same patient, how you can see this is the mass, this is the superior vena cava, this is the azygous vein, this is the aortic arch. So we can show the relationship of the mass with the vessels. So that is also very helpful for the surgeons, and we can also show the bony anatomy. So it is very helpful in decided the approach and what structures you need to cut to access that. So the same patient I have again rotated to show that where the mass is, like here you can see this is the mass, which is and these are the vessels, this is the aortic arch, this is the, from the anterior perspective we have, this is the brachiocephalic artery, and this is the mass, this is the superior vena cava, and from the right side you can see the mass is bulging more towards the right side. This is the superior vena cava, this is the azygous vein, these are the pulmonary vessels. So I would end my talk with this. So we have many techniques. Of course CT has some radiation, but if for any reason CT has been done, then we can use that data to assess the airways, and these are many techniques which can be used.